Hello, I am Eli Adashi, Professor of Medical Science at Brown University and host of Medscape One-on-One. Joining me today is Dr. Donald Berwick, the Administrator of the Centers for Medicare and Medicaid Services. A long-standing advocate for better and safer healthcare, Dr. Berwick is at the helm at a time of great change. Never in recent memory have we engaged the twin challenges of quality and cost with such intensity. At times like this, it is hard to think of a better person to lead the charge. Welcome.
Thanks, Eli.
Absolutely wonderful to have you.
It's nice to be here.
As we reflect on the last 6 months at least, and I know it's been longer, it's breathtaking. And I know we can't cover it all, but perhaps we can hit some of the high points. One of the most striking developments that took place is really the establishment of the Center for Innovation for Medicare and Medicaid. Can you say a few words about how you think about it, what it has accomplished so far, and what do you see as its role going forward?
Well, as you said, in the Affordable Care Act, the new law that's guiding a lot of our work toward a better healthcare system, one of the real gems is the Center for Medicare and Medicaid Innovation, the Innovation Center. It was funded by Congress at $10 billion over the next 10 years. And it operates on a very unusual and very promising set of rules which give it more latitude to actually find and sponsor and support changes in payment and in delivery of care, innovations that can show us the future, that can be lanterns for where we need to go. It has the very special authority, the privilege of when it finds an innovation that works, it can report that to the Secretary of Health and Human Services, and she can convert that into rulemaking without going back to Congress. So it's an accelerator of spread of good innovation. Innovation in this case means either changes in payment, the way we pay, to support better care, or in delivery itself, or both, which have the simultaneous effect of reducing costs and improving the well-being of the patient. They have to do both, or if they're going to save money, they at least have to hold the well-being of the patient the same. So it's a way to find some answers to this very difficult passage we're in healthcare to find a sustainable future for a really, really excellent healthcare system. I think of it as actually a release mechanism. I just think the imagination around this country, the number of people with really good ideas, the number of places that are trying to find a way to more sustainable, better healthcare, it's enormous. And if we really have a way, and we do now in the Innovation Center, to find these gems, to support them, to prove further that they found something great, and then to spread that news, both through communication and, when need be, regulation, we have an answer to a lot of our problems. I really trust the American healthcare workforce out there to find great new ideas, and we need them.
Has it produced so far for you or for us as a nation in terms of ideas that are worth mentioning, perhaps to our viewers?
It's still a fledgling, so it's all of its projects are in early days. It was set up in November. It announced immediately 4 project areas, one on federally qualified health centers, one supporting better community transitions from hospital to home, and those projects are just getting up and running now. Probably the most exciting thing now that's been announced was about a month ago. Secretary Sebelius and I announced the largest investment in our nation's history in patient safety. That echoes in better care and lower cost, what we're after, and the Innovation Center is sponsoring that. Innovation Center is putting in half a $500 million into a support system to support work on hospital-acquired conditions, complications, and there's an additional $500 million, so a total of $1 trillion, a total of $1 billion going into support of change in hospitals and in communities to get lower injury rates to patients in healthcare and better transitions and fewer readmissions. It's pretty exciting. We're going to see that start to get traction this summer.
Perhaps we can think of it as a translational research institute.
That's a good good way to look at it. People talk of a think tank. This is a do tank. It's going to make things really move fast, both by releasing energies around the country, but also by commissioning work. It works through contracts, not grants. It's not a granting agency like NIH or ARC. It will issue contracts for work that it needs done, work on community care transitions or work on patient safety. Or we have a very interesting project called Pioneer ACOs, Accountable Care Organizations, just announced by that center, which will support a cutting-edge group of perhaps 30 organizations around the country that want to really show expertise in helping care be very coordinated and seamless for Medicare beneficiaries who are still in the fee-for-service Medicare program. That's a really interesting idea. I'm very excited about it.
The center is really at the core of virtually any innovation, any new initiative that has transpired and will likely transpire in the foreseeable future.
It can be a home for innovation and encourager, but it's not alone. We have great partners in ARC, and we have demonstration authorities that are not in the center. There's a tremendous amount of innovation going on around the country, so it's a very important piece of a larger puzzle.
Just around the turn of the year, and I would say just on time, the Physician Compare website went up. Can you share with our viewers your vision for this new Compare site in the near future? But even more interestingly, what do you envision it becoming? When will it incorporate quality measures, for example, and perhaps even other ideas that you may have in mind?
Well, there's sort of there's a regulatory or a legal side to that, what the law is requiring us to do, which I'll explain, and then I think there's a cultural one. Also, the Affordable Care Act does require us to have public information available about physicians. That's now set up as of December 2010 on the Physician Compare website. Right now, that website contains information on where a physician was trained. It tells a bit about their qualifications. It's possible to find out, are they contributing information to the Physician Quality Reporting System, PQRS, not what they're reporting, but are they reporting anything at all. Over time, the richness of that information will grow. We're required to have quality information about physicians on that website by 2013, and over time, downstream, the projection is that will eventually be linked to physician payment. So we're meeting requirements to have information more and more available about physicians. That's all done in a testing mode, so that we're currently engaged in pilot projects with physicians in several states, trying to figure out what quality information is useful to display. Does it help the physicians? Is it useful to the community? But the way I think about this is really beyond the regulation. It has to do with learning. I'm a fan of learning. I think we all can learn to do better. And one of the essential resources for learning is knowledge. It's transparency. So it helps us all to get more and more knowledge about how we're doing. So whether you believe on the market side, it's good to have the information out there so people can choose physicians according to performance or pay for quality, which is a plausible theory, or you're just interested in learning. I want to know that Dr. Adashi knows how to do something better than I do, and I can learn from you. You ought to be a fan of this kind of progress toward transparency. And we're not just seeing with physicians. There's hospital compare and nursing home compare.
Of course.
I think more and more daylight's being cast on the work we do, which should help us give care better, not just be paid differently.
You had the responsibility, and I would say the privilege, of crafting the very first national quality strategy.
Yes.
Do you think of it as a blueprint or as a backdrop for everything we do from here forward?
Yeah, it's a really valuable document. I mean, we're in I think and hope, an era of tectonic shift. The plates are shifting. We're coming out of an era where payment went with volume. The more you did, the more you got paid. We're moving in an era where quality is the watchword. The better you do, the more you get paid. We have support systems for quality now. We have metrics for quality. We know so much more than we ever did before about how to orient a system toward doing what we want, which is to restore and preserve health. And I think we're well underway toward that kind of progress. And I do think it'll be better for us all. It's hard. All transitions are difficult. But what did we become doctors for, Ellie? It was to do well for our patients. So let's do better. Not that we're not trying now, but with new information, electronic health records, the value of learning systems and incentive payments that really move us toward thinking about the patient's needs and support us to do so, things can get better.
Going back for a moment to a concept you already mentioned, the accountable care organizations. Yes. This may be a good opportunity to share the latest with our viewers. It is a truism that this is a concept that is much talked about. It is probably a truism that some concerns are raised
Yes.
Regarding the concept and its implementation. What are your thoughts about where we stand with the ACOs at this time, and how do you look at it as it unfolds going forward?
Well, first, the context. I've thought since I came into this role more and more that we're on a great national expedition. We're searching together. We want better care. We know what it looks like. Sometimes we are able to give it, but we understand what great care is. We just have trouble executing. We have trouble doing that all the time. We're too busy. The payment systems aren't aligned. We don't have the information we need. We haven't been trained to work in teams. The institutional structures are in our way. There's a lot of barriers. Now we have to get through that into the care we all want: safe, effective, patient-centered, timely, efficient, equitable care that's fabulous. The Affordable Care Act and other policy in government gives us a suite of tools, a suite of possibilities for helping us all move in that direction. And government's not alone in this. This is a public-private partnership, and the private sector is moving the same way, as you see in both the professions and the payer community. We all want seamless, coordinated, safe, good care. To do that, we'll need different tools and instruments. The Accountable Care Organization, the ACO, is one instrument. It's a pretty exciting idea. It's to be able to forge coordinated care possibilities in a fee-for-service payment environment. Before that, people would have said, oh, no, the only way you get coordinated care is to have some kind of lock-in or managed care environment. But can we reward and support coordinated care for chronically ill people, for prevention, for us through our journeys through lives in a fee-for-service environment? The ACO is a bet that we can do that. And so what it does, it proposes to align patients with organizations by watching the patient's behavior. If Mrs. Jones sees Dr. Adashi regularly for Mrs. Jones' primary care, then she is, and you want to be part of an ACO, she's in the ACO panel. So it's done by watching what the patients do. Patients don't lose any choice. They can go on. Mrs. Jones can go tomorrow and see a different doctor if she wants. She's just a normal Medicare A and B beneficiary. But if she sticks with you, and you were an ACO, she's in your panel. Now you get to help her. You get to figure out, how can I anticipate her needs? How can I coordinate her care better? How can I make our care really attractive so she stays with me? If she goes in the hospital, how can I make sure she has a good experience going home? If you do that and her care improves and you save money, you get to share in the savings. So it's shared savings in a fee-for-service payment environment with very strong monitoring of quality, because we don't want to encourage you to withhold care from Mrs. Jones or save money that way. We want to encourage you to do better for her. So we watch her care, assess the quality, and if costs fall, you share in the gains. That should produce more cooperation between you and others who are caring for her. It should give you a real opportunity to think differently about the way you give care. But put resources where the patient needs it, not where a fee-for-service system that's just organized around volume would normally take us. So it's paying for what we want, quality.
One question we hear in that context has to do with the future role of the time-honored small medical practice.
Sure.
That we all knew and still do. Does it have a role? Can it meet the expectations of some of these massive changes? Can it deal with the meaningful change requirement of electronic health records and the like? What can you say to those of our viewers who are still maintaining what has been a long-standing American tradition?
Well, when you're talking to me, Ellie, you're not just talking to a pediatrician, you're talking to the son of a solo practitioner, general practitioner for 45 years in a small, rural Connecticut town.
In a word, you know.
I know.
the issues at hand.
Yeah, I respect it. I love it. What I saw my father do in the classical rural solo practice, to me, still is the heart of medical care. And if we lose that, we lose something really important. I think there'll be communities where large medical groups or integrated organizations will form and thrive, and they should, but there'll be plenty of parts of our country that are going to have the demographics of small practices. What I think will happen is that for physicians in those contexts, finding in this new modern age better ways to connect together with each other, to have the support that comes with being connected in ways, sharing knowledge, sharing ideas, sharing plans, to have the infrastructure that allows you to take a patient with a serious form of cancer or advanced heart disease and guide them through what's going to be a complex system, even if you're a rural solo practitioner, and then get them back into your hands. All of that coordinated, integrated, modern view of care, we ought to find a way to make that compatible with this small practice environment, which so many of our physician colleagues still practice in. I'm confident we can do that. Is it the same as ever? No, there's change. My father would be scratching his head right now. He'd say, well, how do I do that? What does an electronic record mean to me? Do I really want to be on a team? Accountability, what is that? And we would have to help him get through that journey into the better world, the one where he is supported and he is connected and he can be sure that his patients will get the best possible shake and the health they want. I think we can get there. In guiding CMS, I'm thinking all the time about pluralism, making an environment in which many, many different kinds of contexts can thrive and people can find their way to their answers.
You mentioned earlier Partnership for Patients,
yes,
the important initiative launched not all that long ago, especially the community-based care transitions and the all-important issue of hospital readmissions. What is happening at this point with respect to this initiative? Are you looking for applications, for demonstration projects? What would you like to tell our viewers in terms of being responsive to this initiative?
Well, the Partnership for Patients is probably the most exciting thing I've been involved with since I came here. We have, as I said, $1 billion of support going out there. It'll go out through states and healthcare systems to provide technical assistance so that physicians and nurses and hospitals can understand best practices with respect to patient injuries, and also community care transitions. We'll be putting out requests for proposals for community care transitions, and in the safety part of it, we're going to put out contracts in which we're looking for entities all over the country that will take responsibility for clusters of hospitals to help them become safer and reduce readmissions. Readmissions are a very big deal. We can certainly use tremendous physician energy on this problem. In Medicare, 1 out of 5 Medicare patients who are discharged from the hospital are back in the hospital in 30 days. And according to the science and the analysts, 3 out of 4 of those readmissions are unnecessary. If we're able to smooth the transitions, those people would stay home where they want to be, and costs would fall because they're not deteriorating. We have a tremendous amount of possibility there. That's on the pull side. On the push side, there's contingency here. Starting in 2013, hospitals will have payment reductions who are in the poorest end of readmission rates, the highest readmission rates, and we need to help them really learn how to be players in continuity of care. Physicians will be pivotal here. There'll be roles for them to participate in improving safety, in working on continuity, and it's crucial.
You're making reference, I believe, to the hospital readmission reduction program for
Yes.
which the proposed rules are now on the Federal Register, which complements really the partnership initiative. Does this say to all that hospital readmissions are a huge priority for CMS?
Very big priority. The 20% admission rate, that translates into unnecessary readmissions for 2.6 million beneficiaries a year, a $26 billion a year cost to the Medicare Trust Fund, and we're not talking about out-of-pocket costs. And all of this is happening on the private side as well, so this is affecting private pay costs. I think readmissions are a bellwether of whether we're really doing the kind of support and education and outreach and coordination that really can keep people as healthy as they possibly can. Some readmissions are needed, some are planned, but a lot of them can be avoided if we really support the system to do for the patient what it wants to do. The partnership for patients is not about the downside. That's not about penalties or costs. That's about help. We're reaching out. Let's figure out how to do this right.
Would it be fair to say that you are in the midst of devising a multi-pronged attack on the issue of hospital readmissions?
Yes, and we're not alone. So much that's going on now that's interesting and I think productive in Medicare and Medicaid and CMS is mirrored in the private sector. So private payers, employers, and physicians and systems are all focusing on the symptoms of a fragmented system in order to foster coordination, which is what we want. If money were no object, we'd want coordination. That keeps us healthy. It keeps us with our loved ones. So yeah, this is, as I said earlier, it's a suite of activities, public and private sector, and not just in CMS. And I think readmissions are a great bellwether. So is patient safety. So is patient-centered care, making sure that care plans and patients in control of their own care characterize the system we're in, where patients are kind of the boss. And I think that's what we really want to get to.
It is difficult to speak with the administrator of CMS and not raise the perennial issue of threatened reductions in provider reimbursement as dictated by the SGR formula. Recognizing that this is a congressional responsibility and therefore not necessarily your domain, still, what might you be comfortable saying to our viewers who are providers in this connection?
Well, we're all in this together. I mean, I don't think any one party can solve the problems of physician reimbursement. In the long run, the solution to the problem of physicians being secure about their incomes is the same as the solution to American healthcare overall, a sustainable, high-quality system focused on doing the right thing for every patient every time and reducing costs by improvement. That gets everybody out of the dilemma. So partly we need to keep our eyes on the long run here, which is better care, better health, and lower costs through improvement. That's the three-part aim we talk about all the time in CMS. Better care, better health, lower costs through improvement. Every physician would be well advised and, I suspect, willing to become part of that, generating that solution. In the meantime, we have legacy anomalies, this sword of Damocles of the sustainable growth rate, the SGR, which is a rather complex situation, but over time, because of a law that required physician payment not to rise faster than the cost of living, but it did, and we kept avoiding that problem. We're now stuck with about a 30% gap between what physicians are paid and what the law actually says they should get paid. Each year, Congress has maintained that difference, and the bill has grown. That's a sword of Damocles, as I said. It hangs over the head of the physicians who shouldn't be facing a 30% cut, and hangs over the heads of patients. I mean, who wants their doctor to be worried about can they get through? Mm-hmm. The president is committed to fixing the SGR, working with Congress to do that. And the president's budget submitted this year, he has a 2-year fix, which just gets us enough time to do some thinking. It won't be easy. We're going to have to find some really interesting new ideas in order to get through that. But the president's committed to working with Congress. It is Congress's lead on this, but we're in this together, and we're going to work on finding our way through that, even while we're doing the very important longer-term job, the investment in better care, better health, and lower costs through improvement. If we do that, SGR finally will be a distant memory only.
Earlier in your career, you practiced as a primary care provider.
Yes.
We've learned today that your father was a primary care provider. Obviously, you and most reasonable individuals see great value and importance in primary care medicine. The Affordable Care Act has gone out of its way to support and encourage primary care. Do you feel we are doing all we can? Do you feel we are addressing the issues optimally? Or would you like to see other initiatives undertaken? And if so, what would you like to see done?
Well, first I should confess that it's a three-generation bias because my daughter, Jessica, my third child, is now in primary care residency and will be a primary care practitioner, and she loves it as much as my father did and as much as I did. I'm committed. We're doing a lot. The news is pretty good. In the Affordable Care Act, there are some neat changes which will help increase the robustness of primary care. There's a 2-year increase in payment for certain primary care practitioners. There's coverage of preventive services, which is important for primary care because now Medicare beneficiaries have an annual wellness physical, and they have first dollar coverage for certain preventive practices. All of that should be good for the patients and good for primary care. There are investments in teaching health centers, which is a very exciting idea to train young people in the setting in which they'll learn about the beauty of primary care in the
community health centers.
Community health center. It's yeah, I'm very excited about that. So there's a whole range of investment, plus working parties. I'm part of a working party co-chaired with two of my colleagues in HHS on how to improve the well-being and the robustness of primary care workforce in our country, and I'm delighted to be doing that. It'll have to be multi-pronged. There's no one solution here, but we'll need to work hard on payment rates so that it's financially attractive to be in primary care. On support systems, I think actually there's a relationship between progress toward electronic health records in healthcare and a more vibrant, satisfying, and doable primary care job. I think as we modernize information, primary care will get more and more attractive. So we're forging ahead on all fronts here. It's something we really do have to solve. I'm very excited about some of the technological innovations I've seen around support systems that allow expertise to be distributed more widely, telemedicine, remote care options, especially for distributed in rural settings. I know we can get this one right, and hey, that's why I chose it. It's the best place to be.
Speaking of education, you mentioned the teaching centers, but perhaps we can take it or expand it beyond that. What do you see evolving for graduate medical education, if you will, in the next year or two, partly dictated, partly not, by the Affordable Care Act in terms of resident caps and the like? None of us could ignore the recent budgetary cuts that were applied to pediatric residency training programs. We realize it's a complex fabric. What light can you shed on the near and perhaps not so near future of GME across the board, not just pediatrics, of course?
Medicare and Medicaid, as you know, are significant funders of graduate medical education in our country. So it's an issue we are taking very, very seriously. We know that we have to be very supportive to the educational mission. We need to invest in the future of the workforce. And so making graduate medical education support more and more aligned, more strategic is an important idea. Exactly how to do that, I don't know for sure yet. We're looking at it, talking with our colleagues in the academic world and academic community. I think a thematic notion would be that just as everyone in healthcare, every other stakeholder in healthcare needs to be thinking about better care, better health, and lower costs through improvement, that's also a message and a need with respect to the training of young physicians and nurses and pharmacists and all practitioners. What do we need to do in the preparation of the young so they can be even more effective stewards, even more effective champions of better care, better health, and lower costs through improvement? That involves new skills, attitudes involving knowledge of systems, teamwork, patient-centeredness, all of which I think are making their way into medical education, but we need to accelerate that. And the distribution of the kinds of training that are going on should reflect the needs of the future. The Affordable Care Act does give us some latitude. It allows us to take residency slots that become available by closure of a hospital or downsizing of a program and reallocate those slots where they're needed socially, and that's an important step forward. But I agree with your premise entirely. We need to be more and more thoughtful and strategic about nurturing the robustness of primary care. And that isn't just about doctors. That's about nursing and others who can participate in the primary care system.
The trustees of the Medicare Trust Fund have recently released their latest report
Yes.
Indicating that perhaps the longevity of the fund is now somewhat foreshortened because of the recent economic downturn. I surmised, however, from some of your comments a degree of confidence in the ability of the various payment reforms and perhaps the various quality initiatives that are currently underway to really have a salutary effect on ultimately the longevity of
Sure.
the trust fund. Perhaps you can expand on that sense of yours that much is happening that may in fact offset some of the concerns and perhaps make those concerns at least less ominous as they might sometimes seem.
Well, I am an optimist, you're right, and I think for good reason. First, we've been in a heck of a lot more trouble without the Affordable Care Act. You know, what the actuary said in this latest report was that the trust fund would have gone insolvent in 2016. Instead, that's now out in 2024. It was 2029 until the recession, and then due to the recession and a few other factors,
Right.
as he modeled it, it came back to 2024. But that's breathing room. That's some time. We have some time. Not much, but we have enough. What I know is that better care can be lower cost. That's the core lesson I've drawn from my career. It's what I understand both as a theoretician and a practitioner, and I've seen it. I've seen hospitals and clinical settings around our country, and not necessarily just famous ones, that have taken seriously the idea that better care, more coordinated, more seamless, safer care, more care with more dialogue in it, with more attention to the real needs of the patient, reduces costs. It is more sustainable for communities. There are communities in our country, Ellie, that are operating at healthcare costs that are a significant fraction below the median in our country. I mean, we're talking 25 or 30% less costly, where some of the best care in our country exists. We can find our way to it. With the Innovation Center in our hands, with ACOs and bundled payment and medical homes and health homes and value-based purchasing and all these tools that the Affordable Care Act brings to us, we have a shot. We have a shot at as a nation in finding our way to that better care. In many places it exists, and the problem is one of spread and learning and getting things lined up properly. So I know it's there. When people say it can't be done, I feel like they're saying nothing, you can't have a flying machine and there's an airplane going right overhead. And I say, well, look at that. There's one. And that's how it is. The answers are in our hands. Physicians are key. Every physician faces a choice today, if you ask me. One is a choice of gripping the present and saying it's only, we have to just do what we've always done and get through this storm, and it too will pass. And then there'll be the physicians who are going to help create the future. Better care, better health, lower cost. And I think there are growing numbers of them, and they're all over the country, and they're the people who are going to show us how to get through this, doing what we started out to do when we became physicians in the first place.
Finally, and on a personal note, you have dedicated your life to the betterment of healthcare. When did you know that this is what you wanted to do, and why?
I'm no different from any doctor I've ever known, or certainly most. I wanted to be a doctor. I wanted to take care of people. And then as you're a physician, you and I both, we take care of people, and sometimes it goes right, and we celebrate, and it gives us the joy of effectiveness in helping, which is what we chose to do. And then sometimes it goes wrong, and you say, why? Why can't this be the way it should be? Why did this person get hurt? Why did this complication occur? Why is the patient back in the hospital when they should be home? And then for me and you too, and I think many of our colleagues, the question is, well, what are we going to do about it? Can't we stop it? At that point, if the optimism takes hold, then you decide to get involved, and that's all I did, and found thousands of colleagues all over the country who really want to do this. That's a really important point, which is I think sometimes government can be perceived to want to do things to people, And that's not going to work here. This is about with people, and the people that really count the most are the people giving care, because they want to do the same thing we want to do in government now, which is bring great care to our country.
Thank you.
Thank you.
On that note, sincere thanks to Dr. Berwick and to you, our viewers, for joining Medscape One-on-One. Until next time, I am Adashi.